Hi, and good afternoon. Welcome to today's webinar. I'm Phil Schaefer, Regional Director with the American College of Healthcare Executives National Office. Before we get started, I'd like to go over a few items. For the purposes of noise control, your lines will be muted for the duration of the session unless there's an active discussion towards the end, at which point you may unmute yourself to talk. You will also have the opportunity to submit questions throughout the discussion in the chat panel, so please feel free to submit your questions as needed. Excuse me. Today's session is worth 1.5 hours of face-to-face education credit. In order to receive your credit, you must attend the session for at least 60 minutes or more. To ensure your credit is applied, please be sure that you're using the Zoom platform on a computer or the Zoom app on a smartphone or tablet. Also, be sure the name that you're using for your Zoom session matches the name of your registration. Please be sure to complete the evaluation for this session. The evaluation link will be posted in the chat box shortly. The session is being recorded and will be available in our learning management system within 2 business days. And with that, I'd like to introduce Mike Kendall. Mike, I'll turn it over to you.
Thank you, Philip. Again, thank you for the introduction. I'm Mike Kendall. I am the outgoing SAHA president at the University of New Mexico, and I'll be moderating this along with my fellow student, Cata Cardenas. I'd like to start off first by introducing our 4 distinguished panelists. First off is John Paul Sanchez, MD, MPH. He is an Executive Associate Vice Chancellor in the University of New Mexico Health Sciences Center's Office for Diversity, Equity, and Inclusion. Dr. Sanchez brings a unique set of skills and experiences amassed throughout his career, including working as a health department epidemiologist, founder and board member of several community-based organizations, dean for diversity and inclusion, a healthcare provider, researcher, and educator. Dr. Sanchez has dedicated more than 25 years to diversity, equity, and inclusion-related work and is nationally recognized for pioneering pre-faculty development. He has published 52 peer-reviewed publications and 6 book chapters and served as editor for Succeeding in Academic Medicine, a roadmap for diverse medical students and residents by Springer. His publications have highlighted the voices of many groups, including women, sexual and gender minorities, underrepresented racial and ethnic minorities, Hispanic, African American, Black, American Indian, Alaska Native, and Asian, especially through intersectional lenses. Dr. Sanchez received his medical degree from the Albert Einstein College of Medicine, completed his residency training at Jacobi Montefiore, and is board certified in emergency medicine. He completed a Master of Public Health degree with a concentration in the epidemiology of infectious diseases from the Yale School of Public Health. He is of Puerto Rican ancestry, gay identified, and was raised in the Bronx, New York. Welcome, Dr. Sanchez. We also have Michelle Reeves. She is a Vice President and Chief Inclusion and Diversity Officer at Presbyterian Healthcare Services, a private, not-for-profit integrated healthcare system in New Mexico, and the state's largest provider of healthcare. In her role, Ms. Reeves oversees an enterprise-wide inclusion and diversity strategy designed to champion initiatives and programs that cultivate an inclusive and equitable environment where everyone is valued and empowered for success. Ms. Reeves has served as a leader and practitioner in diversity, leadership development, and educational coaching in global and national organizations for over 2 decades. Prior to joining Presbyterian in 2019, she served as the head of diversity and inclusion for a Fortune 500 wealth management organization and served on the board for the Tampa Bay Nonprofit Leadership Center. She was recognized in 2018 as a top diversity executive by Black Enterprise Magazine and won 2 national diversity awards. She was named one of Albuquerque Business First's 2020 Women of Influence. She currently serves on the executive board of the Albuquerque alumni chapter of Delta Sigma Theta Sorority Incorporated, a private not-for-profit organization whose purpose is to provide assistance and support through established programs in local communities throughout the world. Ms. Reeves earned her master's degree in industrial organizational psychology from the University of Central Florida and her bachelor's degree in psychology from James Madison University. She earned her professional certified coach credential in 2012. Welcome, Michelle, to the panel. We also have Kate Cartwright. Dr. Kate Cartwright also has an MPH degree. She is an assistant professor in the School of Public Administration at the University of New Mexico. Her research delves into the barriers of health equity in the U.S. healthcare system, with priority focus on public health inequities experienced by Latino and immigrant populations. She teaches in the Master of Health Administration program and the combined BA-MD program. Her primary teaching areas are health administration, management, and policy, prioritizing culturally responsive care, pursuing health equity, and program and policy evaluation. She currently serves as a co-chair of the NMHE Diversity, Inclusion, and Health Equity Committee, and as a member of the ACHE Programs, Products, and Services Committee. Dr. Cartwright earned her PhD in sociology with a focus on social inequality and medical sociology from Emory University, and an MPH in health management, administration, and policy from New Mexico State University. Welcome, Dr. Cartwright. Also, we have Andrea Botero, encompasses an extensive experience in organizational development, healthcare equity, community organizing, community lead research, and grant writing and management around healthcare topics. Her work is deeply informed through her advocacy and health equity of marginalized and vulnerable constituencies, one that interweaves a social justice lens to the development of programs. She currently works in performance improvement, value-based programs at Presbyterian Healthcare Services, and heads community-led programs through Salud Morena. Her outside interest includes hot yoga, the intersection of traditional and conventional medicine as an administrative topic, ethnobotany, reading, the arts, and outdoor activities with her family and many dogs. So again, welcome all the panelists to today's speaker series. Instead of slide decks this time, we're actually going to be asking questions, and we will take turns, Kata and I, of asking those questions of a primary respondent or a lead respondent, and then the rest of the panelists will be able to follow up with any thoughts or other ideas on the question that's being asked. So Kata, I'll turn it over to you to introduce yourself and lead off with question number 1 for Dr. Sanchez.
Hi everyone, my name is Maria Catalina Cárdenas. I will be your moderator today with Mike. So this first question is for Dr. Sanchez. Our attendees span many organizations, service units, and years of experience in healthcare. For those who are not well versed in the area of day, what are the traditional definitions of diversity, equity, and inclusion in the context of healthcare administration? Also, of the three, which one do you perceive to be the biggest current challenge for the entire industry?
Well, let me begin by saying thank you so much. Buenos tardes. It's a pleasure being here with all of you. Let me send my regards to Vice President Reeves as well. I'm excited to be presenting with you and all of our colleagues. As we start this conversation of diversity, equity, and inclusion, one of the things that we often do at the University of New Mexico is do a land acknowledgement. And I think that is a very important thing to do, especially as we consider who we serve in the state of New Mexico. So some of you may be familiar with land acknowledgements. I'm just going to share often what we share at the University of New Mexico. So in our land acknowledgement of our indigenous people, we recognize the original people of New Mexico, Pueblo, Navajo, and Apache. And often what we recognize is that since time immemorial, these communities have had deep connections to the land and have made significant contributions to the broader community statewide. And as a university and as healthcare systems, it is important to recognize their history and step forward to serve in any capacity as possible. As we talk about diversity, the recognition of our indigenous communities is one type of diversity and one type of difference in human diversity. Often when I talk to my learners or my faculty or staff, I'll cite definitions of those three terms from the Association of American Medical Colleges, because that's my lens, right, in my training within a medical school, as well as a public health school. So often when I use the term diversity, I'm using the definition that it embodies inclusiveness, mutual respect, and multiple perspectives and serves as a catalyst for change, resulting in health equity. In this context, we are mindful of all aspects of human difference, such as socioeconomic status, race, ethnicity, language, nationality, sex, gender identity, sexual orientation, and so forth. I started in using a bit of Spanish because that is a part of my diversity. Both of my parents are Puerto Rican. In my signature line on the Zoom, I use pronouns of he, him, el, which is a form of my diversity. And so as we're talking about diversity, equity, and inclusion, I also ask you to share those components during this discussion, if you haven't changed that on your tagline, but also use the chat box to share who you are as a diverse individual. Do you identify as a certain racial ethnic group, of a certain geographic background? So I do ask all of you to take a moment and share your diversity in the chat box. And that, to some extent, in asking you to do that, and participate in the chat box is a form of inclusion. Inclusion is commonly defined as a core element for successfully achieving diversity. Inclusion is achieved by nurturing the climate and culture of the institution through professional development, education, policy, and practices. And the objective is creating a climate that fosters belonging, respect, and value for all, and encourages engagement and connection throughout the institution and community. And thirdly, when we talk about equity, the definition that I use is it's the absence of avoidable or remediable differences amongst groups of people, whether those groups are defined socially, economically, demographically, or geographically. I think it's also important to know that although I've shared the definitions that I use of diversity, equity, and inclusion, other terms have emerged within our communities, such as justice, fairness, belonging, that are sometimes captured within the definitions that I shared, but have become more, have had a bigger role in the lexicon of the work that we do. In answering the second part of your question, and I'm just going to take a moment and see if anyone shared their own diversity. And I want to thank Rachel for sharing an aspect of her own diversity. And I'm still going to encourage everyone to use the chat box and share a dimension of yourself. And so in thinking about some of the challenges, I would say it's not that one is harder than the other or more challenging. I think in being a part of this work for several decades now, it is the reality that DEI is a newer concept relative to maybe teaching or research or clinical care. And we probably haven't invested as much time in coming up with competences or best practices. That is a reflection of our history. And it's also an opportunity of where we can go in terms of our DEI work so that we can have greater alignment with our clinical efforts and have better outcomes. So that's what I was hoping to share in response to that question. Thank you.
Thank you so much, Dr. Sanchez. Maybe Kate, Michelle, or Andrea, do you have any thoughts about these questions?
Okay, maybe you should wave. So this is Michelle Reeves. Really, it's a pleasure to be here, and what an interesting topic at an amazing time in our history, when we're starting to see polarization be a regular part of TV and life, and just the opposite of what we're trying to do with diversity, equity, and inclusion efforts. So I run this function for Presbyterian Healthcare. We're the largest healthcare system in New Mexico. We serve a third of New Mexicans. It is really important for us to think about our community and who we serve. And so I have a different answer to what's most challenging. For us, we have for over 15 years thought about equity. We do over 30 studies per year. We plant gardens in low-income communities. We have community health centers that we've built here, really investing in how do we help all of New Mexico have fair, have healthcare that they need, access that they need. Next week, we are launching a mobile vaccine hub. It will go out twice a week to communities that can't get to the normal vaccination hubs. So that seems to be, I wouldn't call it easy, but I would certainly say it's very evident and very present. It's very clear what to do. It's very clear that we still have work to do, but it's easier to do. I find that the diversity piece, even knowing, acknowledging who you are, like you are in the chat. Thank you so much for some of these answers, because you're actually sharing who you are. I find that is a lot easier these days. I've been around for a long time, and in the last 5 to 10 years, people have been much more open about who they are, making sure that you're aware of what community you belong to, making it very clear on a Facebook or an Instagram who you are and what you support. Those things seem to be fairly easy. What doesn't feel easy inside of a system or an organization is inclusion. And what that really means, the depth of it and the complexity of it, it's not just about, oh, come to my party or have a seat at the table. It's really, and it feels like people don't understand that having a voice, valuing what somebody actually shares, valuing, for example, what people put in this chat, even right now. Is that inclusion? Is that the extent of inclusion? Probably not, right? It goes much deeper, much wider, much grander than that. And so the real question is, where do you start with getting people to understand? It's not very apparent how far we go with it. And I think that's probably the harder part of it being in this space in healthcare right now is where and how far do we extend inclusion and the behaviors that follow. I'll hand that over to the next person, Andrea.
So I am honored to be in this panel with such esteemed presenters. So thank you so very much for the invitation. Cognizant of Dr. Sanchez's definition, I'm going to answer this from a small non-for-profit grassroots lens, which is often informed by social justice. For us, it is the interweaving of equity and inclusion that we find really hard as it relates to sustainability, capacity building, and leadership. In the multiplicity of the definitions, when we look at equity as being part of the distribution of resources by institutions or systems, and inclusion as being able to participate, we need to look at who is being funded. According to a study conducted by Echoing Green, only 4% of funding is received by Black or Latinx-led organizations. And if we look at larger bets, like multi-year grants or larger amounts of money, in 2014, only 11% of funding went to organizations led by people of color. And from that 11%, only 1/3 went to that same one organization. And as a direct result, only 8% of executive leaders in thriving non-for-profit organizations are people of color. And it diminishes to the very, very small digits, the 1.0 digits, when we speak about health-related small grassroots non-for-profits. Kate?
I think the conversation that's starting here is really powerful. So one of the roles that I took on when I started my job here at UNM is I teach a class on culturally responsive care, cultural competence for healthcare administrators. And I think one of the exercises we start with is a list of I am statements. So similar to what Dr. Sanchez is having us think about today is writing those I am statements, who are you? And then teasing out which things are, as a sociologist, ascribed or achieved statuses. So what are things that we choose and that we develop on our own, like becoming a sociologist or going to school, or types of activities that people are interested in, becoming a parent, and what are things that are, those are achieved statuses, and for ascribed statuses, what are things that we're born into? And thinking about both the opportunities of those and the challenges that we face because we live in a society that is stratified by race, by gender, by sexuality, by disability, all of those pieces, and how to come up with plans to serve them. I came across a quote this week as I was thinking about this class or this session. This was on a podcast, Brene Brown's podcast this week, and the guest speaker was Aiko Bethea, and she is works in diversity, equity, and inclusion spaces. She's has a JD from Chapel Hill, and this quote was, "Transformational culture work is always relational, not transactional. Real diversity, equity, and inclusion belonging work is not about a checklist, it's about relationships." And we talk about the definition of cultural competence versus something like cultural humility or responsiveness. And cultural competence leads us sometimes into that checklist mentality of, we need to do stuff for accreditation, we need to show that we are hitting our boxes, hitting our target populations, and how do we shift from that into thinking about relational work and thinking about relationships and making that the center. I would say one caveat I would put on this is, if we make it only about relationships, we might be missing some of that accountability or policy level work for how we get diversity, equity, and inclusion like at the center of what we do. But I really thought that that quote was a powerful place for us to start thinking about things today.
Thank you, Dr. Cartwright.
Thank you, guys. With question one behind us, that puts pretty much on track with this amount of time allotted for every question. So next question is for Michelle as the lead respondent, with everybody else chiming in thereafter. Michelle, organizational level DEI initiatives tend to be complex. For example, they often simultaneously solve internal issues such as hiring and administrative processes, while solving external issues such as delivering equitable care to patients. This is a three-part question. How do practitioners prioritize and get buy-in for DEI initiatives? And is there any resistance, and how do you and your team respond?
Oh, I love this question. So for everyone, like I said, in healthcare, it's fairly easy for us to look at the patient perspective. There are many surveys, documents, there are large organizations who help every healthcare organization assess how are we doing with their patients. Are they satisfied? What's happening for them? And so they call them HCAPs. Those they happen all the time. And so that part, when you say, hey, we should do something for our patients, there isn't anybody in healthcare who won't listen. Not a soul. But when it comes to some of the other issues around who are we hiring, when you look at Presbyterian, for example, we're fairly diverse until you start looking at our top suite, right? The healthcare administrators, the executives, and then it doesn't look so diverse anymore. And so when you start talking about that and making it a priority, and what do we do about our leadership and our workforce, and remember I talked about inclusion and what that means, which is part of the first step of that is giving somebody a seat at the table. Then it's not so easy. One of the ways to prioritize that is I think for us, and what we did is we said, can I get, or at least from my perspective, can I get the rest of the leadership team to see this in a light that's good for business? That is, it's good for our patients. It's good for care. It's good for safety. It's good for quality. And it's also good for us as an organization. Can you also see other organizations doing the same thing? And so there is a group called CEO Action. There are now over 2,000 CEOs who have signed this pledge. And the pledge basically says, we commit to making inclusion a priority for our organization. We will have dialogues across the company. We will make sure that we're committed to educating about bias, and we will look at our policies and practices, and we'll share those best practices. And we'll go one step further, and we will talk with our board of directors. And that commitment is pretty strong. And our CEO, Dale Maxwell, signed that CEO commitment. And it really does a few things. It not only helps us feel like we're not alone in this, but there's something to be and someone to be accountable to outside of our organization. It has been the best thing we've done to really help make it a commitment and help prioritize that. So I would say that's part of the process. How do you make it something that isn't just, like Kate was saying, relationships are great, and how do you help someone be accountable to it? So we created this, and it has been really wonderful for us to see. And as we have seen over the past 9 months, putting this into practice, we have resistance in, I would say it's a different way. There are people, and I would say it's just like the bell curve. Remember the old bell curve? Anybody look at that in school? The old bell curve that says 20% of the population will be all for it, and there's 20% that will be kind of against it, and then there's a whole bunch of people in the middle. Well, that's very much how it works. At least in my experience, it has worked this way. And for those small percentage that do have a little bit of resistance, the resistance is around, I don't see that, right? It's not here, and really needing some proof. And so that's where measures and metrics come into play, where you do need to have, and I think you need to think outside the box, right? It's not just counting. It's all about what kind of impact does inclusion and diversity have on your business outcomes, your patient outcomes, the safety outcomes. There's so many different areas that we could really impact. So much so that for example, now to create even more buy-in is we're putting all of that data together. We're looking at things like on your HCAP scores, you'll see we have a question about nurse listening. So is it perceived that nurses actually listen? We're not doing so good there. We're like the 50th percentile. We could be much better at that. And so you start connecting those dots, and everyone goes, yes, that might be something we need to do. So over the summer, we're looking at our entire strategy, post-COVID, with inclusion at the center, with diversity at the center. What does that mean for us as we're serving New Mexico? And how does it impact every single thing we do? And that includes hiring and all these other complex issues. When you do that, I think you take something that feels complex and you make it a lot more simple. We're making it centralized. And so that has been the way to get some of those resistors from being as resistant and really creating a response, I think, that's holistic, that's synergistic, that really helps us move forward as an organization, and not just one person over here waving a yellow flag or a red one for that matter.
Thank you.
Mm-hmm.
Dr. Sanchez, your thoughts, sir?
So yeah, thank you. I think this is an excellent question, and this is something that we're hired to do. When I think about practitioners prioritizing and getting buy-in. So when I think about that question specifically, I think about who are we here to serve? And I always think about, as a state institution, the University of New Mexico is a state institution. And as such, our number one priority is serving the inhabitants of the state of New Mexico. And we have to reflect, we have to do our homework. Who are the inhabitants of New Mexico? One characteristics that, for personal reasons, I've come to appreciate is that nearly 50% are of Hispanic identity, and 28% speak Spanish at home. And, when we think about health equity issues, linguistic equity is at the top with other equity issues. Yet, beyond investing in a phone line or virtual screens, we do sometimes little more. And I mention that because when we talk about buy-in, it's important to think about, who are we serving? What are some health outcomes that we can aim to address? And we know that linguistic inequity ties to people's ability to comply with medication regimens, follow up on their appointments, understand their health condition. So, it's important to think about all these issues, bring people together, point them out and say, let's tackle this together. This is a common issue for all of us, but that's just one example. And it really, when you think about tackling these issues, you bring everyone together. You bring the community through community-based organizations. I'm so happy that Andrea mentioned the community-based organizations. You bring your hospital systems to figure out what everyone is doing. What is Presbyterian doing? What is UMNH doing? And then you start training people to do it differently, right? Our learners, our faculty. So it's teamwork, teamwork, teamwork around a priority.
Thank you, Dr. Cartwright.
So my position's obviously a little bit different as a professor of healthcare administration, but one example that I have about meeting some resistance and a really powerful overcoming that resistance was one of the first times I taught this cultural competence class. And I had a student who came in and said, I'm a white man, this is all just going to be about me doing things wrong, isn't it? And I said, we'll find out. Let's go into it. But the one thing that I was in the middle of was transitioning from teaching a traditional age undergraduate students to mid-career adult students. And that was a big shift for me. And one of the most exciting and terrifying things is things I say in class, people go do like in their jobs the next day. And they'll come back and say, Kate, guess what I did this week? Which is always exciting, but nerve-wracking because I have to really mean what I say. The student, was a little bit resistant at first. And I think you have to have really clear expectations for what's acceptable and how you're going to protect and serve communities, but also to meet people where they're at in a process and a journey. And some things that were really compelling for the student were thinking about things like bottom line and good patient outcomes and return on investment. And when he was able to see some of those presentations and cases, he just got really excited. And that ended up leading into him taking real action. And at the time, it was 2015, there was an open comment session for how to interpret the new transgender healthcare laws, which of course is particularly relevant for us to think about today as we're facing some of the most challenging transgender health laws that are being proposed in states all across the country. And he said, I never would have thought about this before. He put together a presentation for our class and then took it to his organization and said, I think that we should make a formal public comment on this law. And this is how I think we should interpret it. It should be inclusive. We should care for people. And he brought it to class and said, this is what I did. This is what we did this week. And he got his organization in. And he wouldn't have done that at the beginning of the semester. But because he saw a number of different ways that it both served his patient base and also benefited his organization, it changed for him. And so I think not to write people off, but to have really clear expectations of what you are going to hold people accountable to, and then try to meet them in a bunch of different ways is one example where we had resistance and it was a really exciting, powerful outcome.
Wonderful, thank you. Andrea, your thoughts, please.
Yeah, so in community-based organizations, in particularly those that are led by minority groups or are led by people from those communities, DEI is often at the heart of its mission and values. I think where we encounter resistance is when we have philanthropic groups or governmental RFPs with defined geographical focus or diverse philosophies or purposes come in. And what happens sometimes is want to survive, we deviate from our strategic plans or from our strategic funding plans. And these congruencies of diverse processes and philosophies often influence organizations' visions and missions and what programs you're going to give out. And it sometimes undermines the people that you're working with. And it also undermines communities and it leaves us confused. So that was my example where I found resistance.
Thank you. Kata?
Okay, this question is also for Andrea Botero. So diversity is multidimensional, encompassing not just race and ethnicity, but also gender, sexual orientation, religion, and more. Understanding individual differences can be critical to delivering care that best meets patient needs. Are there distinctive features of Albuquerque or New Mexico that challenge traditional DEI considerations?
So thank you. So we are incredibly lucky to do diversity, equity, and inclusion efforts in New Mexico. As a majority minority state, New Mexico encompasses such rich cultural traditions. And I want to thank Dr. Sanchez for doing that land-based acknowledgement, because New Mexico has vibrant Native American heritages. We have 23 tribal sovereign nations, and these nations have diverse cultural traditions, languages, and governmental structures. New Mexico is at a crossroads, from El Camino Real, where you can literally walk through the acequias from Santa Fe, New Mexico to Mexico City, and east to west, a migration that was inspired by Manifest Destiny. New Mexico became infused with not only Spanish and other European heritages, but we have richness in the historical contributions of Asian and African American communities. These routes are not a thing of the past. We're continuing using them today. It's now just called I-40 and the North American Trade Agreement. We have a public health designation within a public health designation. The Mexico-US border region, defined by La Paz Agreement, is an area of land being 100 kilometers north and south of the border. And this area encompasses its own vibrancy and areas of opportunity. We have over 85,000 identified adults as being part of the LGBTQ community. And although we need to do a lot of work, New Mexico is ranked by the Movement Advancement Project at 23.5 out of 38.5 points as it relates to LGBTQ in their policy tally. Because of these multiplicities, we have become aware, like Dr. Sanchez said, of the diverse language needs. As an example, when South American asylum seekers were coming, we knew that we needed indigenous language translations. And my social media was like, did you know a Nahuatl translator? Not only that, but there's also a lot of different dialects within Spanish speaking. My natal Spanish is not the same Spanish that is spoken here. We know it's not just about language, it's about cultural nuances. As an example, depending on tribal affiliation, it may be taboo to talk about the dead, and that affects our advanced directive goals. Yet my children, who are members of a North American federally recognized tribe, the Mi'kmaq, they have a book of the dead, so you can totally talk to them about my advanced directives. We know about tokenism when we're including people in the DEI process. I, as a Latina immigrant, cannot speak about everybody's Latina immigrant experience. Our providers become really good about knowing who to refer, our LGBTQ patients, but also we are really good at our Southern providers become really innovative in the referral process. They know about mixed immigration statuses as it relates to border constraints. So if we have a kid that needs a referral to UNM, that might not happen. They know that because of that truth and consequences immigration point. So they have to be more creative in their referral processes. In addition, we have become more collaborative with our regional partners. Because we're a rural state, we have to mobilize resources, and we see that through the ECHO program. But also we see that with a push pre-COVID of the Southern Border Health Coalition, which was trying to standardize care between Mexico and the US, in particularly around things that we would go to Mexico because they're a lot cheaper, such as ultrasounds. And now we're able to see ultrasounds coming from Juarez that are already translated by a certified translator. And I think because of the vibrancy, resiliency, and pride of these communities, we can bring into our efforts strong humans that can inform programming. I think as leaders, we need to be okay with feeling uncomfortable at many times, but that is a gift because then we're able to navigate multiple spaces in a much culturally humble way.
Thank you, Andrea. Michelle, do you have anything to add?
Andrea, I was thinking I need to get your notes. Those are so comprehensive, right? So comprehensive on what's going on here. Even some things I hadn't heard or actually had real stats on. So yeah, our diversity is, here in New Mexico, I just think it is worth looking at and knowing just how different we are here, and how we can impact that. So I will pass it on to the next person.
Dr. Sanchez?
I agree with Michelle. I'm looking forward to reading your notes as well. I mean, I think that what I really appreciate that you outlined is another descriptor of our state, right? And so I don't think that, well, one of the traditional aspects of DEI that we will face as a state, that's not really a unique challenge, is that in many parts of the country, DEI is still viewed as one dimension, race, ethnicity, which was captured in this question. And it is true, as a minority majority state, people are looking at us to say, what are our healthcare systems doing when you have a state population that's primarily non-white? So, there is a real opportunity to show our excellence in healthcare for that group. In my mind, what has plagued the diversity work is that we're really good at siloing ourselves. Women's rights and efforts are over here, URM efforts are over here, LGBT. We forget the commonality of oppression across many of our groups. And I think that that's something that we still need to work towards. Now, that isn't unique to Albuquerque or New Mexico. It is an opportunity, right? So all these challenges can be opportunities. And really what we need to look at is how our diversity are assets, right? How do we tap our diversity as assets to drive excellence? And so I think that's what everyone has shared. Kate, Michelle, Andrea, a recognition of who we are as a state and what we can do, and then how we can share that with other states across the country.
Dr. Cartwright?
One thing that I just want to emphasize that came up in all these comments is the idea that, and I think it's just that same model, like shifting from cultural competence to cultural responsiveness and cultural humility. Whenever we talk about categories, often people will come in and say, we're going to do like a priority population presentation and hit a different racial group, ethnic group, and too often people come away and they end up reifying or stereotyping based off those presentations. And something I think Andrea highlighted so powerfully is the diversity within each of our priority populations. And so having that, as Andrea said, that culturally humble pivot point allows people to say, I'm going to come in and I'm not going to assume that because someone identifies as Hispanic or Latino, that I understand who they are. Like, I understand maybe a set of questions to ask or things to be aware of, but I can't come in assuming that I know the story yet. And so I think that that's one thing that Andrea just did so powerfully in her summary of who we are as New Mexicans.
Thank you so much. Mike?
Thank you. We're just about halfway through our questions now. I would ask the panelists to just abbreviate your responses just a little bit so we can get to the last three of our questions, and then also go through the cultural competence repository. We'll want to give plenty of time for that. So the next question up, it will be for Dr. Sanchez. According to the American Hospital Association, healthcare facilities that evolve their workplaces to match the makeup of their communities reduce the risk of medical errors, shorten hospital stays, and find new ways to care for the social, cultural, and linguistic needs of their patients. What successful initiatives or best practices has your organization identified concerning community workforce matching? And then secondly, how does the composition of your board and management team reflect the community that we serve?
So, I'll just say two quick things. I am a product of pipeline and pathway programs. If there were not pipeline and pathway programs that were specifically for Hispanic youth, I wouldn't be here, right? Pathway and pipeline programs were there when I was in high school. They engaged me. They built my academic, personal, and professional development. And whether it's a pathway or a pipeline program for you to become a physician, a nurse, a dentist. Those programs are just as vital for those individuals who want to become healthcare executives, right? We need more pipeline and pathway programs where people serve as role models, advisors, and mentors to the next generation. That's my reflection on that. And I think you captured it. We know congruence matters in so many ways. So we're not going to go into that research. Now, the reality is, and I think Michelle shared this, and Andrea and Kate shared this as well, our senior leadership does not reflect our communities. And there's a long history of why that's the case that we're not going to be able to have a lengthy discussion on. Mike, you know, in our School of Medicine, which is where I wear one hat, it's one thing what you check off as a box on paper, right? And I believe I'm the only one senior leader in the School of Medicine that is non-white. As mentioned, I identify as Puerto Rican. I don't think there's any other senior in the senior leadership team of the School of Medicine that's non-white. But I say that because I don't know what boxes everyone checks. And so it's not only about what box you check, it's your visibility and how you step up to serve as a role model and as a mentor. And so I take every opportunity to speak Spanish, say I'm Puerto Rican, say I'm gay, and talk about health equity issues that affect those communities, because those communities have been marginalized historically. So there's not only what you check, but then there's also how you step in and step up. And I think that until we have more diverse senior leadership teams, which we need to work towards, there is still the social responsibility that our leaders recognize who they're serving and address their inequities.
Thank you. Michelle?
I was over here singing Dr. Sanchez's praises. I was doing the amen thing. It's another issue that I think is oversimplified. We just, we just don't know who all is really at the table. So I'll give you an example. Somebody asked me, do we have any openly gay members at our boards? And I said, I don't know. We never asked that. And since they're not open, then by defining, we might have closed or not, but we don't really know. So I think right now, in order to, it's not just the community. I asked our board, I asked them, what voice do you not have at this table? And it was, it was kind of like silence. Oh. Because we don't really know what we don't know. And I think that's where a lot of boards, there's this kind of like, oh, do we have women? But I think about some of these other complex, what you were talking about, Andrea, in terms of all the diversity that we have here. We don't really look and know and make it intentional. So there are some models out there that you can look at. Deloitte is a consulting firm that has a wonderful model for how to build a more diverse board. You can take something like that and use that model to really look at look at a lens and then make some intentional decisions. So for example, we have a board seat open. It will be open in 2 months. And I am at the table actually insisting that we make sure that candidate is diverse, and everybody has to agree on that. And that's what we have to do right now in order to get that diversity at the table and to increase it. I know you said be more brief, so I'm sorry.
Dr. Cartwright.
So in this capacity, I think I would speak to the fact that, like, in 2 roles that I'm playing, like the co-chair with Andrea and DEI, and having been part of that committee for 4 years now, and also thinking about roles that I fill in professional organizations. I'm on the health administration leadership team for the American Public Health Association, and how we make choices and reach out to people. I think what Michelle just said is to take stock. And I think the exercise that JP or that Dr. Sanchez had us do at the beginning that probably needs to be more regularly integrated into board sessions, is doing some of that relationship building and getting to know people. Because if you don't know your board well, and it's just, we come to the meeting, we have an agenda, we check off our lists, then you miss a chance to have your board be really powerful, because if people know each other and know strengths, you can build capacity in different ways. But also I think it means that you can't fill in the gaps. So I think NMHE and our diversity committee, it is about relationships. If you're looking for a committee to join, I really encourage you to join us for our diversity committee work. But I think thinking about some other national organizations, there's opportunities to do a much better job.
I agree. Andrea.
So like Dr. Sanchez, I am also a recipient of the pipelines. Thank you, Dr. Kiran Katira from the Community Engagement Center. I wouldn't be here without her, but I wouldn't also be here by the nudging of community health workers that I was working with. And because of that, I think Salud Morena and all the chingonas in Salud Morena, we are really interested in the co-building of agents for social change. One of our biggest mission and vision is capacity building through leadership, development, training, health advocacy, navigation, and establishing mutual support networks that are community driven and community informed through an indigenous knowledge framework. So pipelines are amazing.
Thank you all. Kata?
Okay, this question is for Dr. Cartwright. So are you aware of any non-traditional, possibly unexpected outcomes healthcare organizations have realized from diversity, equity, and inclusion initiatives or best practices?
So I think honestly, the example that I gave earlier about the student who came in and was not sure and then building, I mean, he surprised himself and he's, surprised, I don't know that he surprised us, but it was an exciting moment. I think that's a story where you can meet people where they're at and people can take a pretty quick journey. It's not always going to work that way, but people have capacity for connection and for change. And I think tapping into that is a powerful moment. But the one thing that I would say, I don't know if this is a surprising outcome, but I want to remind people that in architecture work and community planning, when we think about ADA and disability accessibility ideas, there's an idea in there called universal design. And when you use universal design models to make places accessible for people with disabilities, guess what? Everybody benefits. So I think that's, I don't know if that's surprising, but it's something that I want to remind people is when you use these, you really improve things for your whole community. And it's not going to, by making something more accessible for one group, you're not denying care to another group. And I think that that's a takeaway that sometimes people don't think about. They think that diversity or equity and inclusion is about dividing a pie, and really it's just making things bigger and better and more accessible for everyone most of the time.
Thank you, Dr. Cartwright. Michelle, do you have anything to add?
I do. I was thinking, Dr. Cartwright, you reminded me of the fact of we need to all believe in the abundance mentality. You gain so much, and there's so much more to gain. I think the unexpected outcome for me is there's a good dose of humility that you get in this role. When you take on diversity, equity, inclusion, you're like, wow, it's so much bigger, deeper, wider than I even imagined. And when you take on that perspective, the unexpected outcome is how you grow. I mean, everybody else does, but you do too. And I think that is it's a lovely thing to have. And there's so much more out there. So when you wrap your arms around that, you can, it's joy. It's a joy that I can't really explain right now, except that's why I think we're so passionate about this stuff.
Thank you, Michelle. Dr. Sanchez, do you have anything to add?
I don't have anything to add for this question, but thank you.
Thank you. And Andrea, do you have anything to add?
No, I think Dr. Cartwright and how she said that, trying to deliver care to our most precarious communities and building programs around that, and then everybody benefits. It's incredibly well said.
Thank you, Andrea. Mike?
Thank you.
We cannot hear you.
Sorry, I was going back and forth between windows and deleted my stuff. All right, this is question number 6. This is for all the panelists. Again, everybody's responded so far, had something to say, to share your thoughts on all these other questions. Again, this is for all panelists. Dr. Sanchez will be the lead respondent. Tell us one way the recent pandemic and focus on social injustice impacted your DEI efforts. Dr. Sanchez.
I think it understandably forced many people to have uncomfortable conversations. And I have to grimace sometimes about things like that, not because it doesn't hurt, but if I bore the weight of the disparities in infections and death in my community and other underrepresented communities, I would be crying every day, right? And I say that because COVID did not represent the first pandemic where we saw disparate death. As providers, as healthcare leaders, as healthcare systems, we lived through tuberculosis, syphilis, HIV, AIDS, chikungunya, and that's only the infectious diseases, right? Because, and I'm highlighting that because it wasn't until recently did we even appreciate the weight of housing insecurity, food insecurity, and other forms of violence. We were totally blind to that, in part because we were only really taught the genetics and the biology of health disparities and now. But it forced us to have uncomfortable conversations, and it forced many others to deal with the trauma that communities have been dealing with on their own. Communities of color have had to develop resilience to survive. Now other communities who didn't have to witness that had to deal with the uncomfortable reality of how they contributed to it. That's what emerged most recently in COVID in a way that I think we had forgotten from HIV, AIDS, and other conditions. And we're going to continue to have these uncomfortable emotional periods until we do something different. That is our challenge ahead.
Michelle?
For Presbyterian and for me and my role was created because of this chaos that's going on, the revelations that came about because of the pandemic and what it revealed to all of us. So I say, you can ignore no more. Racism is something I can actually say in a meeting right now and nobody looks at me sideways. In fact, they're all trying to figure out how to better deal with it. And I think that piece is the heightened awareness, the fact that it's not going away. There's a trial going on right now. And all of us are trying to be a heightened awareness. If it doesn't go the way that we think it might go, what would happen here and what would be disruptive? And I think we just have a much needed, it's about time we took it seriously thing going on. And I think that's really been an important part of how it's impacted us.
Thank you. Andrea?
So for Salud Morena and a lot of community organizations, social justice sometimes is part of our vision. But I think what this has done is that we started to really mindfully establish programs from a social justice lens. Like that became the catalyst. And we started thinking about systems of multiple oppressions. And one of the ways where Salud Morena does that is we really try to collaborate with established place-based leaders and organizations that already have ties with those communities that we're serving and that have that psychological safety. In addition, we prioritize Indigenous knowledge or place-based frameworks, we asset map, and we do community participatory research and design.
One thing that I think happened this summer, when both with the pandemic, and I think Dr. Sanchez spoke really powerfully to the weight of inequality, and we're still seeing that. And I think Michelle spoke a little bit about the fact that even though we are having such a successful rollout of vaccines in many metrics, one metric that we aren't is we haven't hit the health equity metric for vaccines. And so how we're pivoting as a state and how both UNM and PRES are taking some big partnership steps in trying to address that gap, I think is really powerful. But one thing that NMHE, and I think it's a different moment for NMHE in some ways, is this summer with Black Lives Matter and with social injustice, is we were able to come together as both DEI and draft a letter, but also when we shared that letter across the board, it was unanimously accepted. And I don't know if that would have always been true. So I think the piece that Michelle said is, there's space for people to consider things and speak about things. That statement's available on the NMHE website. So in a minute, when we share the repository, we'll talk, maybe we can point out that statement as well. But it was a moment where I think people came together and people were willing to consider things and address things that maybe they hadn't before, which is a very small kernel of hope in a pretty overwhelming time.
Thank you very much, guys. Andrea, would you give us an overview, please?
Like I said previously, I feel like we just, for Salud Morena and some community-based organizations, we really wanted to mindfully inject social justice and do everything through a social justice lens. I am so sorry. Is that what you're asking, or an overview of the whole panel?
I think we're shifting into the cultural competency repository grant.
Correct. Thank you. Would you give us an overview of that repository? My apologies.
Oh, you mean?
I humbly apologize. Okay, so the repository came about from a lot of committee meetings, for the DEI committee meetings, under the leadership of Ron Aldrich and Mary Hyacinta. And it was very inspired by Jamie Silva Steele. And NMHE, it wanted to improve health outcomes of marginalized constituencies through 3 capacity building activities. So I wrote a grant proposal to the Con Alma Health Foundation with an aim on increasing access to culturally and linguistically healthcare services through the creation of a repository of curated materials, a policy library, translations, webinars that was accessible to all New Mexico healthcare organizations. And our primary demographic were those organizations that did not have the capacity as larger systems, such as UNM and Presbyterian. We also wanted to increase and diversify New Mexico's healthcare workforce. So we made available university work-study scholarships for work related to the repository. And for that year, we were able to support the attendance of unrepresented groups into our annual conference. We also wanted to promote equity through leadership and organizational policy by fostering through the education of healthcare leaders in diversity, equity, and inclusion. So we brought a speaker from the Disparity Solution Center for that annual NMHE, HFMA, and HIMSS conference. And that was Aswita Tant-McGorry. And she did an amazing job and a great panel for that year. But I think the most magnificent thing that came out of it was the repository that Dr. Cartwright worked so hard with her students.
Thank you.
I'm going to share my screen.
Yes,
and
thank you. Could you share your screen and give us a walkthrough?
Yep. Here we go. Oops. Oh, it says host disabled participant screen sharing. Am I allowed to? Maybe I'm not. So if not, I will post the website and you can find things.
Hi, Kate. I just made you a co-host. You should,
Okay, great. Thanks. Cool.
You're welcome.
And I'll add the link in just a moment. Can you see the New Mexico Healthcare Executives page?
Yes.
Great. So when you go to the New Mexico Healthcare Executives page, which Joseph Marler, who worked with us on the repository, has worked as a student and becoming really a standalone leader in so many ways, has done a complete overhaul of our website. So if you haven't been to our website recently, I highly encourage you to go. But when you go to our website and go to publications, we have something at the bottom called the Cultural Competence Repository. And we developed this repository with Ramya Grantala. She did so much work. She and I talked with a number of different stakeholders about needs and pulled things together. And she worked so hard for about one academic school year. But as you can see, we have ideas for how to go through the repository, general healthcare resources, small clinic resources, contributors about the repository. If people have resources they want to add, it is a dynamic space, so people can send us things and we can add them. But if you go to small clinic resources, you'll be able to see that there are a number of different things. So supporting small practices, lessons for healthcare reform, navigators for the Joint Commission, maternal and health leadership competencies navigator. You can go through all of these different pieces and different resources that will just be fully developed. So one of the reasons why we did this is because, as Andrea said, a lot of our smaller hospitals and smaller clinics throughout New Mexico are working on shoestring budgets. And so how to develop and how to incorporate pieces like DI, which should be central to the mission, which should be things that people are building across the board, they may not know where to go or may not be able to do it. And so in starting the repository, we at least have a number of resources. We're hoping to work with some smaller organizations to do walkthroughs and trainings with the resources specifically. So if that sounds like you, let us know and we can work together on how to utilize the resources available in the training. One other piece that I'll share before we go to Q&A, because I don't want to take too much time. I want Q&A to be vibrant and helpful, but here's our statement on diversity and inclusion, and that's available under our chapter DEI space, and you can see a number of things. And then the one last resource I wanted to share, which I'll put all these in the chat, is that UNM and Prez and other places tonight at 5:30, there's a virtual vigil to honor and mourn in solidarity with Asian American and Pacific Islanders communities, and that's at 5:30, and you just have to register there, but they have a number of different ways to do that, and that is a collaborative effort. So those are some resources. I'll pop them in the chat, and maybe we can take the couple of minutes left over and start the Q&A.
Yeah, I haven't received any questions in the chat, but I'll just leave it up to everybody to take this opportunity. If you have a question, please raise your hand and unmute yourself, and we'll ask some questions of the panelists. If not, I have a wrap-up question. I have two screens here. Nothing on the first screen, second screen. Anybody on the second screen? Any questions? Raise your hand.
Well, I think I want to call out one of our attendees. I'm so delighted to see her. Christina Campos, I'm sorry. I know you're probably just trying to attend, but you've been sitting there nodding your head, and I know you've come to speak to us on so many different occasions about the unique issues you face out where you administer healthcare. Any questions that were particular interest to you, or I saw many head nods, so I know you can speak to some you shared with us some issues and obstacles you struggle with out there.
Well, the entire program, and I think, I remember at one point when we were talking about diversity and inclusion, you think in simple matters first, like where do I stand and how do I feel about the issues that affect me personally. And so a lot of it we're looking, I live in a community that has 85% Hispanic, and my board is half female, half male. I run the Guadalupe County Hospital in Santa Rosa.
Yes, thank you. I don't know if everyone knows who you are. Thanks.
Yeah, Yeah, and I've had the pleasure of being on the AHA Board of Trustees. I just graduated from that, and the DEI, efforts on it have really picked up, and it's wonderful to see, and to see the board members on the board be very representative also of our country. We have African Americans, we have Hispanics, we have a lot of females on the board now. In fact, our incoming chair, Lassiter, is Black, and it's just so wonderful to see that at that high level. But when you think about it, at first you're just thinking in terms of race, like you mentioned. But in my community, the issue is poverty, and the haves and the have-nots, and the ones that live in town and the ones that live way far from town. And how do you reach out to them, especially now during COVID, with vaccination efforts and all that, and being very creative in how we partner with people. One of the things that we did also is because, another DEI issue, and it has with the haves and have-nots, is broadband and access for telemedicine, for registration for the vaccines. And so we just had a huge drive a few weeks ago, early in January, and the DOH supported us in it. We opened it up. We got a case of the Pfizer, and we just said, if you qualify, if you think you qualify, just show up. And so we did the seniors first in the morning because we wanted to make sure we got the seniors 75 and older. And then we did the people with health conditions. And then we did essential workers, which a lot of our people are. And it's, in their poverty, the essential workers are the poor people. I mean, they're waitresses and maids, and right now they don't even have jobs. So it was really good to be able to open up to them, and we didn't charge at all. We didn't tell them to bring an insurance card. We wanted nothing to do with billing. We just wanted people to get vaccinated. So we lead the state in the vaccination. But just like the whole conversation, and I remember like at the very beginning, I put, okay, cisgender and ella, she, her. I'm a first generation Mexican American. My husband is disabled. He had brain surgery a couple years ago and is homebound. My son is gay. My future son-in-law is biracial Black. 6'6" with dreadlocks. Everybody in town knows him. But when I think about it, I think I am America. But until I see through their lens, until I see how difficult it was to get my husband around in a wheelchair or up steps, I mean, it really brought me back to my hospital to see what impediments do we have here? What blocks have we not, torn down? And the way I see how my son is treated. And he's wonderful. He's so open about it. And he lives here in town, and he works at the correctional facility, and he's in care. And his partner, he bought a house, and his partner moved to town, and his another tall redhead. And it is exemplifying, like you said, talk about who you are and be proud of it. And it's exciting. My future son-in-law, to see through the Black community and having to really check my feelings, because we all say, well, I'm not racist. And I'm like, wait a second, I might be. I think I am. And at least acknowledge the fact that I don't know, and start reading, usually in my library, White Fragility and all these other books, and just because I need to know, and I need to be aware of how other people feel. I think the term that you used about humility, cultural humility, that is just so important. And I remember as a Hispanic, as a Mexican American, thinking that we were all kind of like the same. We're not. We're really not. But this panel has been so incredible. It's been so refreshing. I've listened to so many panels around DEI. And I honestly think this is one of the best ones, because it really brings to light how incredibly diverse New Mexico is, and the work that you're doing. Andrea has done incredible work. It's nice. It's so exciting to see her graduate from student and in the MHA program, and now a leader in our community. So I'm just thrilled. I hope I get to meet Dr. Sanchez someday, and the rest of the group, Michelle and Kate. I mean, this has just been wonderful. Thank you so much.
Thank you. I think I have one question here in the chat. One moment. Here's one from Stephen Berkshire. We all think that the younger generations who have grown up with more diversity may be more willing to inclusive, yet based on what we have seen in the media, that may not be true or as true as we wish. Any comments on this sort of trend? And we'll just start off with Dr. Sanchez.
Well, yeah, I think maybe having Stephen share a little bit more about that, because I think that is, there's several elements to that. I mean, just, so I'll give Stephen an opportunity to maybe elaborate a little bit more, and then I'll comment once again on something I already mentioned about siloing. But Stephen?
Okay, finally was able to unmute myself.
There
Yeah,
you go.
My kids grew up in a very inclusive world. Their generation, well, one of them's a millennial. The others might be into the X, but I'm thinking more of the younger millennials and maybe the new Z generation that are coming up, that we assume because of integration in the school, they participate in sports together, they go to a lot of social activities, and there's a lot of dating and that kind of stuff. But yet, and it may just be the media, but we've seen, particularly in the last few years, youth in other parts of the country, or even here in New Mexico, who still seem to harbor a lot of racist particular activities and things like that that we've been talking about today. And so I'm just wondering, what people's opinions might be on how we might, particularly from a healthcare perspective, be educating or helping the younger generations that are in our workforce or the patients that we have to be more inclusive.
Excellent. Thank you for sharing that. And I think the question and the comment that you provided is something that's on the minds of all of us. I think the past 4 years was very difficult for me, like a lot of people in the country. So, I don't think it's one answer. I think we have to be proactive in building safe, inclusive forums to discuss all of these topics. I think we have to do better starting as early as possible in elementary school education. So I don't have an easy answer, but I'm happy you brought it up. I really think integrating more content, not only amongst our health professionals, but starting much earlier in elementary school might make a difference.
May I hop in here? I think one thing in terms of education that we've seen, and again, being a child of the 80s, was really a shift of not to see color, right? We were taught to be colorblind. And I think that one thing that's really helpful, and maybe what's making some things obvious, is we're shifting away from that colorblind pedagogy to say we want to see differences. But as we see differences, some of those prejudices and biases become a lot more obvious. And that's actually a win, even if it feels painful, because then we can see where some of those breakdowns in communication happen, where some of those prejudices lie, and we can, as Dr. Sanchez just said, bring that education in more powerfully and show who people are. Like, the point is not to not see color. The point is to see color, to see diversity, and to say, where are these lived experiences different, and where are opportunities denied based on these differences? So that's, I think, one thing I would think about, the sort of the progression of education. And I love millennials and Gen X and Gen Z, and I'm so excited to get to work with people across all generations.
I have an additional statement.
Go ahead, Michelle.
Just to add to that, there's a wonderful, right now I'm struggling to remember the title of the book. I'll remember it before this is over and actually put it in the chat. But there's another side of this equation. It's not just about racism, it's about what are people actually desiring. And it is the desire to belong. Proud Boys exist because people want to belong. They want to belong to that. They want to belong to something. And so I think about the DEI space being concerned just as much with that. What can we do to help people belong versus, I don't want people to feel bad, but what are they actually, what can they do in place of? You know, when you tell someone to stop smoking, you don't just say stop smoking and they do it. They don't do it, right? They actually need a new replacement, whether we give them a rock or a piece of gum or therapy. We need, we have something that replaces and has a better way or shows a better way. And the question is, how do we do that for our young people? How do we do that for everybody, for that matter?
Thank you, Michelle. We have time for one more question, and it's in the chat before we give some time back to Phil to wrap us up. Earlier in the discussion, it was mentioned that outreach for diversity and inclusion with faith-based communities has started. Has there been some buy-in or not at all or somewhere in the middle? I'll give this one to Dr. Cartwright, please.
It's really interesting you asked me that. So one of the things that, one of my identities is I'm a pastor's kid. So I was raised very embedded and in church communities. And I happened to be raised in a particularly conservative religious tradition. And so I think that so I'm going to say it depends, right? In terms of the different spaces that people are in. But I think that faith-based spaces are really powerful to do outreach to. And I think depending on different religious traditions, you have people of each religious tradition and different denominations within those where there's opportunity to build relationship, to address diversity and racial justice issues. And I think if we look both at a number of the protests and marches and spaces this summer and this fall, and also even looking at the vigil that's going to happen tonight, you have a number of different religious organizations who are saying, we're there. Like, what can we do to support different religious traditions or the leaders in these spaces? And so I think it's a really powerful place. But of course you have the whole spectrum of things as well.
Thank you for that. One quick comment before we wrap up and turn it over to Phil with ACHE is this speaker series today wraps up the SAHA speaker series for the academic year. NMHE will not be holding a presentation next month, but they will be co-hosting one, if I understood that correctly. And I'll let Stetson or Phil comment further on that. But Phil, would you close us up, please?
Sure, Mike, thanks. And thank you to everyone, the moderator, our panelists, and for everyone for attending today. Wow, what a great discussion. This does conclude our session. Again, today's session is worth 1.5 hours of face-to-face education credit and will be applied to your ACHE account approximately 2 weeks from today. Also, please be sure to complete the session evaluation that's located in the chat box. The recording for this session will also be available on ACHE's learning management system within 2 business days. Today's program is copyrighted in 2021 by the American College of Healthcare Executives, all rights reserved. Thanks for attending and continue to stay safe, everyone.
Thanks, Bill. And Mike is correct. NMHE will be working with HIMSS on a co-hosted event. It'll likely be on vaccines and technology. But we're trying not to phrase it or put on an event in a way that anyone who worked on that is going to get attacked by the public. So we will have more coming, and see you soon.
Well, thanks,
job,
everyone.
everyone.
A wonderful weekend.
Thank you.
Thank you, everyone.
Thank you.
Thank you.
Thank you, Christina. I miss you.
You look great, Andres. So good to see you.
Good to see you. We need to get together soon.
I know. Now past COVID, we can start making plans to actually hug.
Yeah.
Come on and get vaccinated here if you're not vaccinated yet. Everybody.
Oh, that's. I haven't gotten called, so I might write down. Go to Blue
Yeah,
Hole.
as long as you qualify, you're in the state registry, just come on out. We have capacity, except we're just doing Johnson & Johnson now.
Okay. Thank you so much.
Andre, you have to introduce me to Christina.
Yeah.
Christina Campos, this is Michelle Reeves.
So nice to meet you, Michelle. So
Nice to meet you too. It's always good to see people doing a lot of work in the community. And we've been I actually missed a Department of Health call trying to do as much as we can to really, get it out. I think there's been so many different different efforts. And now it feels a little bit more like, okay, like you've thrown it out there.